Good morning, everybody. It's a great pleasure for me to be here today, and thank you for the organisers for inviting me to chair the session. I want to welcome the audience that we have in the This one? Okay, wow. All right. Let's keep on going. So the session that we have today for this morning, important session for me, and I'm very pleased actually that we have this topic to discuss. We're going to focus on the plight of the Rohingya population, arguably one of the most marginalized and vulnerable population groups that we have in the world right now. I'm going to set the context very briefly, and then I'm going to hand over to our three presenters. So in the early hours on 25th of August 2017, the Myanmar military launched clearance operations in Rakhine State as a response to coordinated attacks by Rohingya armed groups. This resulted in an estimated 688,000, mainly Rohingya people, fleeing to neighboring Bangladesh. The speed and scale of the displacement resulted in a critical humanitarian crisis, which we have been responding to right now. Currently, sorry, this is probably just me. Should I step back a little bit from the microphone? Right, I'm going to stand right here. Can you still hear me? Okay, good. The current situation still remains very precarious. As all of you know, the populations are living in makeshift camps. It's an area that's prone to cyclones and heavy rains. It's a very densely crowded population. Access to safe, clean water, hygiene and sanitation still remains a problem. And of course, high risks of preventable or vaccine-preventable outbreaks. So we have three presenters today. We've got Mitchell, Kate and Melissa. We'll be describing the mortality surveys that MSF conducted in Bangladesh, and then describing two outbreaks that we witnessed, diphtheria and acute jaundice syndrome. So as Prince said, in terms of timings, that we'll get all of the presenters to come up, and then please, we'll leave the questions and answers for the end, and I'll make sure that we have enough time at the end. So, first presentation is by Mitch. Let me just quickly introduce Mitch. You all have the bios in the pack, but Mitch is a medical doctor with a postgraduate degree in international public health from the University of Queensland in Australia. At the time, last year, Mitch was the medical coordinator for MSF, directly in Bangladesh, responding to the crisis. So Mitch, please come up.
It is indeed an inspiring moment to be here today. Good morning, and thank you, Sid, for this introduction. First, I must say that it is a very big privilege for me to present this very important work of MSF in highlighting the main finding of this mortality survey. The survey was performed last year in the Rohingya refugee camp in the Bazar district in Bangladesh during the peak of the emergency crisis, which has often been described as the world's fastest growing humanitarian crisis seen in the recent human history. A note about the Rohingya I'd like to again mention here is that they have often been described as the world's most persecuted minorities, with an estimated population of over 1 million and primarily residing in the northern Rakhine state in Myanmar. They have often been known to be subjected to decades of systemic persecution and discrimination, which has often resulted in a displacement crisis in this region. Prior to the influx or the big outbreak that we have seen last year, there was we witnessed a similar situation in the 1970s and again in 1991 and 1992. before again witnessing the same situation last year. So I will not go into this second slide, as the Sid has already mentioned about the background of the influx. So I'll just go to the third slide. In less than a month following the influx, 500,000 Rohingyas fled to Bangladesh. Their village have been razed. Some reported that they faced landmine as they flee. Many came with little or very few possessions, and they also reported to have spent a lot of money on transportation to ferry across the rivers, across the sea. As you can see in one of those pictures here, that it was a very common sight to see lots of Rohingyas carrying their old age family members who could not walk, and they also reported to have walked for days to weeks before reaching Bangladesh. And when in Bangladesh, they have no alternative but to rely on the humanitarian aid for food, water, shelter, and for healthcare. And also the existing health or essential services that existed prior to this influx, it became under heavy strain because of the sudden increase in the number of people. And all the humanitarian aid agencies, including us, we had to struggle to cope up with it. This makes them the very highly vulnerable populations. Having fled conflicts and witnessing severe trauma, they continue to live in extremely difficult conditions. These are some of the pictures from the settlement. As you can see that the shelter are stretches for miles. It's very difficult to see the end of the settlements. And I remember that during the beginning of this emerging of the spontaneous settlement, we tried to walk for an assessment. It took us almost more than 2 hours to reach from one end to the another. And we had to cross in many rivers, and one of the highlighted moments was when we have to cross the river, which was covered with full of human waste. As you can see that the roads are very precarious, and the bridge is very fragile, and there's no motorable roads to inside the big settlement. So it was a very difficult for our team and for the humanitarian aid agency to get the supply and resource in, and also to refer the serious patients from the settlements. And many of the settlements, they are located in a hilly and an uneven terrain, and others are located in a low-lying area. This makes them very, very vulnerable to the landslides and to the flash floods, which we later saw with the first sign of the monsoon. So in order to understand the extent of this crisis during the beginning of the first few months of the influx, we conducted the mortality survey. The pool crude mortality survey, there was, in total we conducted the 5 surveys, 4 in the northern settlements and 1 in the southern settlements. And these areas were chosen so as to ensure that we cover both the pre-existing population and the new arrivals. And we used 2 different type of methods. We used a simple random sampling for the northern survey, and the systemic approach for the southern survey. And this was done based on the factors present on the ground, such as the population estimates, the arrangement of households, etc. And for the recall period, we used the 25th February as a starting point. This was done to ensure that we have the comparable data over the 6 months of the Rohingya population prior to their arrivals and after the influx. And this also helps us to compare the populations already staying in the settlements, in the pre-existing settlement before and after the new arrivals. And for the survey, head of households were interviewed. They described the family structure and provided the date, locations, and cause of death of the family members who died during the recall period. And in total, our survey conducted interviews with 2,434 households, representing roughly around 11,500 people. As seen in this picture, you can see that the smartphones were used. The random house in the area of interest were selected by chance by random GPS coordinates for the northern survey, while for the southern survey we used a systemic approach using pen and paper. And here are the results. I must warn that it's quite shocking. In the initial months following the crisis, from 25th August to September 26, following the start of military offensive, pool crude mortality rate was 7.6 deaths per 10,000 per day. Here I just like to remind that it becomes an emergency threshold when the crude mortality rate is more than 1 death per 10,000 per day. And here we're talking about 7.6 deaths per 10,000 per day, which was 14 times higher than the same populations 1 month prior to this period and 10 times higher in the period 1 month afterwards. We also collected the mortality information on the vulnerable groups, such as under 5 children and those who age more than 50 years. And the pool under 5 mortality rate was 5.3 deaths per 10,000 per day, which is staggering 33 times higher than the same population prior to this period and 2.7 times higher than the period afterwards. And the pool mortality rate for more than 50 years was 20.6 deaths per 10,000 per day, which was again 12.2 times higher than the same population prior to this period and 11.7 times higher than the population afterward. And looking at the total number of morbidity burden, alarming 73.4% of deaths were reported due to violence-related death, and which was 71% for children. And 67% were because of alleged shooting, 9.9% were because they were burned in the home, 7.8% beaten to death, 3.3% because of the sexual violence, and 1.6% because of landmine. This result shows shocking level of violence, and sadly, children were also not immune. And extrapolation to the total population estimates gives the total number of the deaths somewhere between 6,500 to close to 10,000. This extrapolation is based on the population estimate. We use the very most conservative data. The actual death could even be more. And following the survey, we became very concerned and alarmed with the result. In November last year, MSF published the finding of this epidemiological survey, which created the wave of worldwide attention, which was covered and reported in many news agencies, as you can see here. To summarize the main impact of this mortality survey, United Nations Special Rapporteur, international aid agencies, and human rights organizations and academics used the finding of this findings to highlight the plight of the Rohingya and demonstrate the extent of the crisis unfolding in Rakhine. And with journalists and media persons unable to access Rakhine state, MSF survey provided the tangible facts and had highlighted the Rakhine context within a very clear time frame. And it also shows that the response to the survey, it demonstrated that information when backed by robust scientific method is valued and respected, especially in an era of alternative facts. And most importantly, the government of Myanmar, which has been silent about the widespread violence against the Rohingya, was prompted to react to our MSF finding, challenging the validity of our research. Previously, the Myanmar authorities gave the official figure of total number of deaths at around 500 people, which was in stark contrast to our estimate. So by counteracting this official narrative, MSF provided a reality check on the scale of the crisis and politics at play. Our data is continued to use, and it will also provide the historical evidence in literature, teachings, and potential human rights procedure. In conclusion, we can say that this survey shows a very high mortality among the Rohingyas, particularly due to violence in the first month following the crisis. And sadly, it suggests that they face mass killing prior to their arrival in Bangladesh. And I'd like to highlight this sentence here, that the mortality rates are likely to be underestimated, as the data does not account for those who are still living in Myanmar, or for families who are killed, for all the family members who were killed in Rakhine or during the time of their journey. And I'd like to acknowledge the Bangladesh team in project missions and in headquarters, and all those teams involved in this huge response. And I hope that this survey would continue to inspire and encourage us to speak on the behalf of the vulnerable people, whether we serve in Bangladesh, Myanmar, or elsewhere. And the power of medical voice, ladies and gentlemen, should not be underestimated, as they exposes the plight of the populations in crisis, and it has the potential to catalyze the much needed social and political response. Thank you all.
Mitch, thank you very much. Again, questions at the end. So I want to introduce our next speaker, Kate White. So Kate is one of our medical emergency managers working in MSF in Amsterdam with me, and she's currently responsible for the response that we're providing in Bangladesh.
Good morning. So I'm going to continue talking about the same population and the real-time analysis that we did during the diphtheria outbreak amongst the forcibly displaced Myanmar nationals in Bangladesh. So, as you are already aware, between August and December 2017, more than 600,000 Rohingya fled Rakhine State in Myanmar into Bangladesh. And on the 10th of November, we had our first diphtheria case. Now, as many of you are probably aware, diphtheria is a vaccine-preventable disease. The vaccine has been around since the 1920s, and globally the coverage for diphtheria vaccination has been extremely good. So we have seen very few diphtheria outbreaks within the last 100 years. In fact, the only other large outbreak that has happened was in the 90s in the former USSR. And since then, very few people have even seen a case of diphtheria, let alone a large-scale outbreak. This outbreak, to put it in a bit more of a global context, has happened as one of 5 outbreaks in 2017 of diphtheria, all falling within declining health systems or vulnerable populations. So it highlights the lack of coverage and vaccination coverage and health access to healthcare that this population had. So between the 10th of November and the 9th of December 2017, we saw 440 suspected diphtheria cases. Of those, 168 cases presented on the same day, on the 9th of December, which led us to the question, how big is this going to be? Because actually, as MSF, we haven't experienced a large-scale diphtheria outbreak for a number of years. So MSF approached the London School to help forecast the expected scale of the diphtheria outbreak. This is our timeline. So the first case after it presented, and the delay between the 10th of November and the 6th of December, happens because when that first person presented with diphtheria into our clinic, our medical doctor who first treated this person didn't actually know that this was diphtheria. They didn't recognise it, they'd never seen it before. Completely normal. Not many people have seen diphtheria. They were treated with another form of antibiotic that was not effective. They went back into the community, and then they came back a couple of weeks later and were consulted by a different medical doctor who was older and had seen cases previously in his career. And so then this was the trigger moment for us to be able to go back and see, well, actually, since he first presented on the 10th of November, how many diphtheria cases have there actually been? And at that moment, that's when we got the London School involved to say, okay, how much do we need to prepare? So the assumptions that the model gave are here. it was based around what little information we had on this population in Rakhine State, according to some proxy vaccination indicators that we had around polio, the information that we had from the programs that we ran in Myanmar, the population that was living within the camp, and the fact that we expected around 15% of the cases would be severe enough that they would require hospitalisation. Those assumptions were centred mainly around, given the vaccination coverage, we expected it to be somewhat like the outbreak in the USSR back in the 90s. So this is a graph that that represents the delay in reporting. So as you can see, when the outbreak first starts, there is a massive delay in reporting. That gets better over time, so that's due to the fact that at the beginning the population also had no idea of what was happening, so we needed to get out, sensitise them on what type of symptoms they needed to come forward with, and also put in a system in place for active case finding. And then as that gets better over time, you see that the delay in reporting decreases dramatically. And then the black line is the actual final number of cases that came to us over the period of time. And those blue dots are the cases that were reported. And then so the black line is the extrapolation from that as to how many actual cases we think are in the community. And those red dots are the adjusting for the reporting delay that we see. So as you see, again at the start, it's quite wide because people are not reporting in a timely fashion, and then as we get the sensitisation happening within the community, that narrows significantly. So the first forecast that was run on the 12th of December, you'll see that the red shaded area is the range in which the expected number of cases fall. The red line through the middle is the exact number of cases forecasted, and then the black line is the actual number of cases that were reported retrospectively. At this point in time, we needed to decide how many beds are we going to need for the number of cases that we are expecting. And so what I'd just like to highlight is that other things factored into those bed numbers, including how much physical space did we actually have to be able to put people. Because it's a very condensed area, and we actually ended up turning what was going to be a maternal child health hospital into a diphtheria treatment centre. So the bed need is significantly lower than what we were at this point in time actually expecting the total number of cases to be, which ended up factoring into some of our admission criteria and the actual strategy that we used to treat patients. Over time, obviously, this changed. We got better information in terms of patients that were coming in, vaccination started, our contact tracing was better, and so you see that the model is starting to adjust and starting to come more within the line of cases that we're seeing. Also, we were able to get other information that impacted the amount of cases we were seeing, like the fact that there was a very, very good local market trade happening in antibiotics. So as people became aware as to what was happening, they would go out and they would buy their own antibiotics. And we think that that had some impact on the transmission and the number of cases coming forward. And in the end, it ended up looking quite similar to the actual number of cases that we've got in. So it relatively matches the peak of the diphtheria cases. And indeed, the red shaded range that you see of the forecast is extremely similar to the actual number of cases that we got in. So the conclusions for the model was that it was able to relatively predict the correct scale of the outbreak, but starting from the 20th of December. So there was a small delay between the 6th, where we engaged the London school, the first model run on the 12th, and the 20th where we started to get the really reliable information. And that was because of all these extra details that the model requires to be able to have a really good fit with the expected sort of scale of the outbreak. And according to the model, the R0 was between 5 and 10, so the amount of cases that, the amount of people that one case can potentially transmit to carry on the outbreak. Around 5% of cases were reported, according to the model, and the 5 to 14-year-old age group was the one that sustained the outbreak and continues to sustain it over time. The biggest conclusion, though, that we came out of this was that should we do this again in the future, and it did have massive benefits in terms of operational decision making, we would want the modelers to be as close to the field as possible so that we can reduce that time delay and make the model more effective faster. So what impact did this have actually on our day-to-day decision making? Well, as you saw, it helped us decide around our bed capacity, how many inpatient beds we were going to have, but also who was going to be treated in those inpatient beds. Because as you saw in that first model run, the prediction of the amount of cases versus how many we could actually hospitalise was dramatically different. So at the start, we decided that we would only hospitalise those cases that were severe diphtheria cases and required the use of the diphtheria antitoxin, which is the only form of treatment for diphtheria and is in a global short supply. So at the time, we only had enough to treat 40 patients within the first few weeks. So those cases would be automatically admitted, and then those cases that were moderate to severe but didn't fit our diphtheria antitoxin criteria would be treated there, and the rest would have community-based treatment with antibiotics and vaccination. And this also led to a division between various MSF facilities. So not all MSF facilities at the start of the outbreak had the capacity to treat with the diphtheria antitoxin. It also helped us to forecast the amount needed, and remembering that this outbreak fits in with 4 other outbreaks globally, it made WHO really push some of the Indian manufacturers to speed up the processing and to get more of the diphtheria antitoxin out into the environment. It also made us have a number that we could use to forecast the rest of our international order and to bring in further supplies into the country, because it wasn't just about the diphtheria antitoxin, it was about all of the medical consumables and equipment that would be needed to treat this number of patients. It also meant that we could do 2 things. The Ministry of Health was able to provide us with extra support in terms of medical doctors and nurses to help staff these facilities and treat these patients. And it also provided us with a reason to do surge staffing from our international staff, providing hands-on clinical care to diphtheria patients, which has not been our way of operation previously. So it meant that international staff could do clinical care without being registered with the government body in Bangladesh, and it was given approval at a Dhaka level. It also contributed to closer collaboration, both on the ground and at higher levels with WHO, GON and other actors. So we had very good collaboration with the teams that came in to help open up further treatment centres, and also made us have an initial advocacy around vaccination strategy whereby we could justify a wider range in age group for vaccination. It also highlighted the previous lack of vaccination in Myanmar and the fact that this population had had very little access to healthcare because the global coverage for diphtheria had been so high that for this to happen meant that this population had not been vaccinated in many years. So there's a whole bunch of people that I'd like to thank. We couldn't have done it without our field teams. I mean, we've treated more than, I think, 6,000 diphtheria cases in Bangladesh to date, and we still continue to treat them as MSF, and we couldn't do it without the many staff that worked for us and that contributed to this. So, thank you.
Thank you, Kate. Okay, introducing our last presenter for this session. So Melissa Ivey. Melissa is one of our field epidemiologists working in MSF since 2017. She holds a Master's of Public Health and Epidemiology from the St. Louis University in US. So Melissa, please come up.
Thank you. So I'm going to continue our discussion of the Rohingya settlements in Cox's Bazar district in Bangladesh. Excellent. Okay, so this morning I'll be talking about an outbreak of acute jaundice syndrome that we've been witnessing there and responding to for several months. We've already heard a few times about the context that we're working in, so I won't spend much time here except, is there, if I can figure out a pointer? Just to provide a bit more geographical context, both of the previous presentations were focused on the large settlement in the top of that map, often referred to as the mega camp. It represents about 500,000 refugees living in that area. My presentation deals with that area as well as some of the smaller settlements located in the southern portion of this map that range from about 10 to 50,000 refugees in each of those. Okay, just some background on acute jaundice syndrome. It is a syndrome, so there's a variety of symptoms and signs that are associated with it. Clinically, it's often initially recognized by an acute yellowing of the skin or sclera, the whites of the eyes. And it can be caused by any number of things. There are many different infections that can cause acute jaundice syndrome, including viral hepatitis, leptospirosis, and malaria, among many others. And it can also be caused by non-infectious means as well, such as blockages of the bile duct and as a side effect of some medications. In this context, we were concerned about hepatitis E and hepatitis A, as both of those are transmitted via the fecal-oral route. And as we've heard, there was poor water and sanitation conditions throughout the settlement. Our first case was recorded on the 22nd of October in 2017, and we saw a steady increase in cases over the following weeks. And I want to just point out, it's important to keep in mind throughout this presentation that when this first case presented in October, we were currently responding to an ongoing measles outbreak and had an important role in supporting Ministry of Health in mass vaccination campaigns throughout the settlements. And as this acute jaundice outbreak continued, as you've just heard, diphtheria also emerged, and we had a massive response to that as well. So this was happening while these other two large outbreaks were also occurring, and so there were competing priorities for time and resources and space and all of those things associated. So just keep that in mind as we go through this. So our objective here is just to describe this outbreak in terms of the etiology of disease and some of the epidemiologic factors as well. So to do this, we analyzed the patient line lists that were collected in MSF health facilities in the various settlements over about a 6-month period between October and April of 2018. We were able to have serologic laboratory confirmation performed during 2 different time periods. At the beginning of the outbreak, we were collecting blood specimens within the health facilities and sending those to the national laboratory located in Dhaka. But because of the number of cases we saw, we quickly overwhelmed the laboratory there. And so we're not able to continue doing that until World Health Organization, in collaboration with the Ministry of Health, were able to coordinate some additional testing that occurred in March because of the duration of this outbreak. Apart from that, we were relying on rapid diagnostic tests, or RDTs, that were used within the health facilities, and we had those available for hepatitis B, C, and E. I think for B and C, we had plenty of supply. For hepatitis E, we were also limited in the number of RDTs we had available. And as a result, we had to prioritize what we called high-risk or priority cases, and that included pregnant women, as they have a higher mortality rate from hepatitis E, suspected clusters of illness, patients that had severe enough illness that they required hospitalization, and any cases that presented from the surrounding host population. So these were the cases that were that RDTs were used on in the health facilities. We also had an Epi Alert team that was started in about mid-February, and they were able to actually go find the household where cases lived, do active case finding, and they collected GPS coordinates of that household using the Kobo app on smartphones. So we were able to do some mapping from their work. Okay. In total, over the 6-month period, we documented 1,775 cases of acute jaundice syndrome. And of those, we were able to collect blood specimens and have serology completed on 293 cases, roughly 16% of the total number of cases. It's unknown how many rapid tests we used. The positive results were well documented, but the negative results weren't as accurately noted, so we don't have a denominator for the number of tests we used within our health facilities. And the table here shows the results of this testing. So for example, for hepatitis A, we had 173 specimens or patients who tested positive for hepatitis A via serology, representing 59% of those samples that were submitted. We did not have a rapid test available for hepatitis A, and so that 173 represents 9.7% of the total number of cases of that 1,775. For hepatitis E, we identified 6 cases through serology and an additional 4 cases by RDT within our health facilities for a total of 10, or 0.6% of our total sample. And you can see here that for 86%, we still don't know what the etiology is. They were unconfirmed. This is our EPI curve. So this represents the number of cases per day that were recorded in our health facilities. And as you can see, there was a steady increase until roughly mid-February. It sort of leveled out for about a month, and then around mid-March, we started to see a decrease in cases. And each of the etiologies is shown here in a different color, and from this you can see that they were present throughout the course of the outbreak. Hepatitis A is indicated by the dark orange, and you can see that was occurring throughout. Leptospirosis you only see showing up in the later days of the outbreak, but that's more to do with our testing capacity than anything else. We weren't really testing for that earlier on. Okay. 780 of our cases were female, and we had information on pregnancy status for about 75% of those cases. Of that 75%, 14 pregnancies were recorded. One patient was confirmed to have a hepatitis C infection. One patient actually tested negative for all 5 diseases we were testing for: hepatitis A, B, C, E, and leptospirosis. And the other 12 have an unknown etiology. They did not receive testing. They fell within the period of time where we weren't testing. The average age of cases was 13.3 years. And the graph here shows the number of cases by age in years. So as would be expected, hepatitis B and C infections had a significantly higher average age. Patients with confirmed hepatitis A infection had a lower average age of 7.7 years. We also wanted to look at the spatial distribution of the cases to try to identify whether there were clusters or pockets of disease where we could intervene. 41 cases, or 2.3%, were recorded among the host population. Our cumulative attack rate was 24.2 cases per 10,000 population. And you can see here I've listed the highest attack rate was 70.8. The lowest was 16.8 cases. And the higher attack rates actually occurred in those smaller settlements to the south that had a smaller population. Our case fatality rate was 0.4 deaths per 10,000, which is consistent with other hepatitis A outbreaks in recent years. So the Kutupalong and Balakali mega camp, that large one at the top of the map, accounted for over half of our cases. And this is where our EpiAlert team was working to locate the households and do some additional mapping. So that's what is shown here. 61% of cases actually were reported in these health facilities. And of those, we were able to locate 297 cases, or 27%. We focused on cases that had been confirmed by labs. And some of the reasons why we weren't able to locate some of those cases is because, as I mentioned before, this EPI team didn't start until mid-February, so cases that had presented before then were not located. And oftentimes the information we received from the clinics was incomplete, and we weren't able to locate the cases based on that information. So in this map, households were aggregated to 100 square meter blocks in order to protect patient confidentiality. And the size of the dot represents the number of cases. So the larger the dot, the more cases in that area. And as you can see, it's really spread throughout the entire camp, or the entire settlement, excuse me. We didn't really see any clear pattern of disease. It really was sort of all over. A couple things I do want to point out here is that in Camp 17 and 20 along the western border here, those were very sparsely populated throughout most of this time frame, so that's why we don't see many cases there. And then in the top, I really wish I had a pointer, in the top Camp 1 east and west, we can see there are some larger dots, so that represents a larger number of cases, and so we think there may have been a potential cluster of hepatitis A cases in that area. And this pattern that we see here, this is for all cases regardless of etiology, but we saw the same pattern when we broke it down by cause. And in response to this, we performed or conducted some additional training within the health facilities on the use of RDTs in order to increase our uptake of having those performed on our high-risk population, the cases that we had identified as higher risk or priority cases. We also continued to have water and sanitation interventions throughout the settlements, and in fact, in that area where I pointed out we suspected a potential cluster, there are water systems that are currently being installed there, as well as a fecal waste management site to try to curb some of the spread of disease. We also, when hepatitis E cases or these suspected clusters were located, the water and sanitation team went out and performed soap distributions among that community, set up bucket chlorination points at the various water sources there, and also did some hygiene promotion. And our outreach team also began to follow up on patients that weren't returning to the clinics for treatment after their initial diagnosis. Some of the limitations that we faced were that, as I've mentioned, we had very limited lab testing available, and so we weren't able to get a complete picture of what the etiology or what the cause of this outbreak was. And even for those that we were able to test, some of those actually tested negative for all 5 diseases we suspected, and so we don't know what that is. We have incomplete mapping. We weren't able to locate all of the cases, and we weren't able to do this activity in the areas with the highest attack rate, so we're missing some information there as well. And as I mentioned, there's no clear pattern of disease that emerged. And again, we were dealing with other outbreaks at the time, which created some competing priorities. And so in conclusion, hepatitis A was found to be a major underlying cause of this outbreak, although we did see many diseases present, including hepatitis E and leptospirosis, which may worsen during the monsoon season. And so we recommend that there's ongoing surveillance and vigilance around this to watch for changing trends, to see if we are witnessing a change in the etiology or a shift in the disease patterns. Thank you.
Thank you, Mitchell. Thank you, Kate, and thank you, Melissa. So we're going to get into the Q&A session. So I'm just going to reiterate a couple of rules of the game that Prince went through earlier. So if you do have a question, we have people with mics in the room. Please speak clearly into the mics. Please say who you are and also which organization you work for. And please do keep your questions concise. Please also just nominate which of our speakers you would like the response from. I will try and prioritize our online audience, so Diva, just put up your hand up if we have a question from one of them. Otherwise, I will open the floor up for questions. We've got one here. Can we have a mic?
Hi, good morning. Thanks for the presentation. And I'm Amit, Oba India Medco. So my question is for Kate. Kate, so this was regarding the vaccination strategy and the advocacy component for the diphtheria outbreak. From my experience, in India also, we had one diphtheria outbreak in Kerala, and we also got similar kind of a picture, not in the magnitude, but the age shift was very much there. So the older patients getting the diphtheria outbreaks, and this is the same thing which we got in Rohingya crisis also. And this is exactly what, when we talk about the vaccination strategy right now, we are focusing on, when any country talks about, they just talk about first, second, and third dose. They miss on the second and the DT fifth year dose. And that's why this age shift is happening, and I mean, like, we are getting these kind of things. So probably once we have these kind of outbreaks, in terms of vaccination strategy and the advocacy, are we going back to the, so for example, are we meeting government officials of Bangladesh or Myanmar so that they think about the older age groups, and so ultimately, otherwise we'll keep on having these kind of outbreaks because the susceptible cohort for the old age group is increasing. Huh?
Yeah, you are extremely correct. Yes, we are going back and doing advocacy with the Ministry of Health in Bangladesh, WHO and others. But as we all know, vaccination is a complex and also highly political. So far we have not been able, because actually it would be ideal if we could get above 15. So at the moment it's vaccination up to 15. But we see a change in the outbreak as we got good coverage for up to 15s. Then it's actually the adults who are now continuing the transmission, because also in Bangladesh they have had their primary series, but there is no routine vaccination for the 4th and 5th doses in your adult population. So they've become susceptible again. So indeed, we continue the advocacy to get wider age groups for this population, and I think the thing that, for me, you can put together from the 3 of these presentations together, also with the fact that we had a continuing measles outbreak, was this is a highly neglected population that has had very little access to any kind of vaccination or healthcare where they came from.
Thank you.
Okay, any other questions? We've got one at the back just there.
Thank you. I'm Dr. Manisha Khate from National AIDS Research Institute, Pune. And my question is to Melissa regarding the hepatitis outbreak. And you have mentioned that is acute hepatitis syndrome, and looking at A, B, E, and C types. The modes of transmission are different for the types, but you could see them at one time. And how many of them had co-infections, and what were the vaccination strategies? Did you went back with because vaccines are available, so what was the response looking at the cases?
Okay, you may want to have a response to that.
Yeah.
see, is this on? Okay. We did see a small number of cases who actually had co-infection with hepatitis A as well as either B or C. I don't have the specific number off the top of my head, but we did see that in a small number of cases, yeah. And as Kate said, vaccination is often very political. We weren't able to do any vaccination campaigns in relation to this outbreak. I don't know if you want to say anything further.
As many of you are probably aware, within Bangladesh as a whole, hepatitis A is endemic. It is not a part of the routine EPI schedule. And so that is indeed one of the barriers that we face in terms of vaccination campaigns for this, because to do a vaccination campaign, we would be looking at around 20% of 1.2 million people plus the host population, which for many countries is not financially viable. Hepatitis A is not a cheap vaccine. So given the amount of cases that we were seeing versus an immediate impact of water and sanitation activities, so that was our first priority, is to stop the route of transmission and then to look at vaccination as a later stage.
Okay. I'm just checking our online audience as well if there's any questions yet. Not yet, okay.
I'm Himanshu, I'm epidemiologist of India OCA mission. I have a question to Kate. So in your predictive analysis or predictive modeling, at what time in the epidemic did you do the predictive modeling?
So the first model was generated on the 12th of December, which was a month after the initial case. But in terms of when we realised we actually had a diphtheria outbreak, it was only 2.5 weeks from the moment when we actually realised there was a diphtheria, because there was that delay between the initial case first presenting on the 10th of November and them getting a misdiagnosis and then coming back, and the initial diagnosis of diphtheria happened, I think it was the 28th of November, if I'm correct. So the time delay was 15 days between realising there was a diphtheria outbreak and being able to do our first round of modelling.
Other questions? Go on. Pete.
Hi, Pete Masters from MSF UK. Sorry, Kate, this one's for you as well. You talked about the kind of the modelling geeks and getting them closer to the field, and I use the word geek with much respect. How do you think that might work practically?
For me, I see it working similarly to some of the other positions we've implemented in MSF. So now, I mean, for this emergency response, one of the first positions we had on ground was a GIS person to help with mapping in general, and then also mapping around various diseases. For me, I see it in a similar role. You would deploy a GIS person, you'd also look at deploying a spatial modeler, and they'd also be able to work together to be able to come up with hopefully as correct model in a rapid amount of time.
Good morning. Thanks for the opportunity. I am Prerna from Maulana Azad Medical College. My question is to Mitchell. You said that you used random sampling while conducting the survey using smartphones. But I believe that in humanitarian crisis, people might not be having access to smartphones. So can you touch upon that?
Let me just go ahead. Yes. Thank you for the question. Well, I think the smartphone were used by our survey team. So, for the northern survey, we used a simple random sampling where the selection of the houses were purely selected by chance based on the GPS coordinates.
And just to add to what Mitch says, so one of the things that we have in the last few months produced is actually a kit which can be deployed straight away. It has a number of smartphones in it, all of the techie stuff, and I'm not technical, but it has all the techie stuff that you need to then be able to do a number of different things, including both the mapping and also the software on it to be able to conduct surveys.
Hi, Bhargavi Rao, MSF UK. Question to Melissa. The samples that tested negative for everything else, do you have any plans for those samples to do anything else on them, send them away for additional analysis? Any thoughts on what might be going on?
Yeah, at the time there were no additional tests that were planned. Again, I think because of the fact that we were responding to multiple things at once. And this is something that has, we were seeing a very low case fatality rate. It was not identified as one of the things to prioritize, so there weren't any additional tests that were being conducted. I don't know if that's changed.
While I'm waiting for other questions, I'm just going to take the opportunity to ask Kate a question. On the lines of Bhargavi, future efforts to really capitalize on one of the largest diphtheria outbreaks that we've seen, how else will we use the data to take our lessons learned?
So at the moment we're looking at not only doing a sort of epi-descriptive piece, but really analysing the clinical outcomes of all of the patients that we've seen. I think we've learnt a lot over time in this outbreak, not only around the use of the diphtheria antitoxin, which has quite some serious side effects and needs quite a high level of clinical management, but very practical things around how you can get around some of those side effects of the diphtheria antitoxin, how you can avoid some of those in terms of practical application. Lessons learned around contact tracing, follow-up of patients, some of the sequelae that we've seen over time. We managed to do 30, 60 and 90-day follow-ups of those cases. So I think in the next couple of months we will see substantial scientific publications around the diphtheria outbreak. There is a new guideline coming out in terms of the treatment and is really capitalising on the lessons that hopefully we've learnt from this outbreak that we can take into the next. And then for me the biggest take home is that we will continue, as we see health systems fall into decline, seeing the re-emergence of some of these older diseases. And so there needs to be a link there in terms of there has to be something better than the current diphtheria antitoxin, which the reason why it has so many side effects is because it's produced using equine serum. So more effort needs to be placed in terms of R&D as well on better treatment options for these patients.
Okay. Other questions from the audience? Anybody online? Oh yeah? Okay.
Good morning, my name is Eva Delvink. I'm from NRC Handelsblad. And I wanted to know, what is the current status of the diphtheria outbreak?
Mm-hmm. It is continuing to have low-level transmission, so around 30 cases a week. Sometimes it goes a little lower than that. And it comes back to the first question that we had. It's because we're seeing actually now more adults sustaining the transmission. So we've got good coverage both in the host and the refugee population in your under 15s. But because the adults had not had their booster vaccines, they're now susceptible, so we're seeing them continuing on the transmission.
Just because we started discussing and just in continuation of the same thing, because I mean, adult susceptible cohort, but also like, are we kind of targeting for any surveillance mechanism? Like, in India, what we have right now is like we have started working on at least for surveillance, and from few states we're getting good numbers. So right now we are having this adult susceptible cohort, but are we also focusing on or pushing the government or us for doing the surveillance for at least for diphtheria?
So there is a surveillance system in place, so it's not for lack of picking up these patients. So the government already had a facility-based surveillance system in place, and then that has now been extended to include community-based surveillance and also routine surveillance in the form of EWARS. So anyone who's familiar with it, the WHO EWARS system, which collects information from all of the health facilities that are operating within the area. So I don't actually think the issue is not so much the surveillance. The cases are getting picked up and they are getting treatment. The issue is more around extending that vaccination to include over 15s. And honestly, until that happens, we're not going to see a great improvement.
What we found out was because the case definition was not very clear for many doctors. So once we strengthened the surveillance, we started getting more patients, and then the investigation started. Then we knew, okay, there are cases of diphtheria, which is going to the adult side. So I know surveillance is there, but it also depends on the quality and,
At the moment, the case definition is definitely sensitive enough, because what we see in the testing is actually a number of people on laboratory testing being screened out. So, yeah, but indeed that can be an issue.
I am Manus from Pondicherry, working on one of the private hospitals. My question is for Melissa. So you mentioned there are 5 cases which didn't have a diagnosis, right? You didn't know what are those 5 cases. So did you try to find out, to doing some further investigations actually about those 5 cases?
Sorry, can you repeat the last part?
There are 5 cases you didn't have a diagnosis. So did you try to did some further analysis or further investigations? Because those are clinically suspected, right?
For those that didn't have a diagnosis?
Yeah.
Yeah, so as we saw, most of the cases we weren't able to diagnose definitively. And we are continuing to use RDTs, and we are continuing to do testing with that high-risk population. But as I mentioned before, there are no plans to do any further tests outside of that grouping of hepatitis virus as well as leptospirosis.
Okay.
Buddhaditya from MSF, and a question for Kate once again. So one of the reasons for the diphtheria outbreak was poor vaccination coverage in Myanmar. Is MSF doing anything about that? The field teams present there.
I'm going to hand this one over to Sid.
Sorry, just so I'm clear, your point was, what are we doing in terms of the Myanmar side?
Yeah, because one of the reasons for the outbreak was the poor coverage.
My overall response to that is I think it's very challenging for us, but also all external international organizations trying to actually work in Rakhine State. I mean, for us, we have limited access in terms of providing any form of access to basic healthcare at all. So it remains a challenge to even just simply be there. Any other questions?
Sid, this is a question for you. Mitchell had some very important words to say about using the power of the medical voice. How does MSF intend to capitalize or move on from this with the Rohingya, but also, is this going to, I mean, what was very important about this was really using data as a driver for our advocacy, which some accuse us not always of doing, and it's been a while, probably since Darfur, that we've really used our medical data to exercise our voice. Do you think this will change the way perhaps we do data collection in our operations, but also how are we going to build on this, what we've very successfully achieved with the Rohingya crisis?
So a couple of questions there. Let me try and... I think what, for me, this reaffirms is as Mitch said, the power of the medical voice. I mean, our obligation, our responsibility as MSF, but also as any humanitarian organization working in these crisis-affected areas of the world, we have a responsibility to not only use our data, our medical information to improve the services that we're currently providing, but also that far wider reach. It is to expose the suffering, the plight of the populations that are going through this crisis, and it is to to provoke that social or political response. I think this just reaffirms, for me at least, that is the role that we do. It clearly puts an emphasis on the robustness of our data collection systems. I think that's something that MSF has been working on over the years. The data collection, the routine data collection that we have, but also the opportunities to actually do additional things, the opportunities to do operational research, that is additional data collection. That all puts pressure on our field teams. They're having to just manage the day-to-day operations. But I think it's the combination of having robust information that is reliable and also our ability to use it. In terms of the Rohingya situation, I mean, at least for MSF, when we put out the press release in December, it was one of the biggest picked up MSF stories for the year. Unfortunately, despite other organizations, despite the messages being out there, I think the situation we see for the Rohingya populations remains extremely challenging, and this is where MSF and others should be urging governments, should be urging the global community to come up with structural solutions for the Rohingya population at the moment. It's a difficult one. I don't have any specific concrete answers for that. Any other questions? I think we're coming to the end of the session. We have, I think, 5 minutes because I think we started off. Let me ask one last question to all three of the presenters, putting you on the spot a little bit. So all three of you were involved in the operational response. So from each of you, just key lessons learned from the time that you spent in Bangladesh and the involvements that you've had with the operations. A couple of key lessons from each one of you.
Mitch, you go
first. Yeah, well, it's very difficult to put a key lesson learned in one single sentence, I would say. But from my personal experience, I think like the key lesson learned that I like to put forward in context would be the coordination, because it was a very big influx. There was already lots of humanitarian organizations working in this very narrow strip of Cox's Bazar district. And we learned that we spent a lot of time and resources in coordinations, and I think which was very, very important to be able to cope up to this type of massive emergency crisis.
Yeah. I think with that, one of our strengths that came on ground and continues to is the fact that almost from the very beginning, we try to get a community-based surveillance system up and running. And it has paid off in dividends over time as we see multiple outbreaks happening, as we try and have a grasp of what's happening within this community. We still are one of the few actors whose surveillance system does not exist purely in a health facility. And for me, that is a massive point, yeah.
And I would say, I think having, from the very beginning, strong collaboration, of course, from the medical side, but also with water and sanitation team, and having them involved in planning and in response, as many of the outbreaks and many of the things we faced there were related to water and sanitation conditions. I think it's important to have them involved.
And to capitalise on that, link that with the reporting that we do. So for every medical report that goes out, there is a link with water and sanitation so that we can see the correlation that's happening in terms of hygiene conditions within the settlements.
Great. A couple of closing remarks on the session. I think just building on that, I mean, for us in MSF, for the response, it was one of our largest water and sanitation responses that we had for this. It certainly, the overall situation also highlights the enormous risk of vaccine-preventable diseases, the emphasis on routine vaccinations in a population like this. Pete also mentioned it, we're not in isolation when we work in these crisis-affected areas, working in collaboration both operationally, but also from data collection, but also from research, working well with external partners. So for the modeling, working well with academic institutions, working together. And then my My final point was, again, maybe just reiterating what I said earlier, we should not underestimate the medical voice that we have in the humanitarian sector. And organizations like MSF, we should be using our reliable medical data to provoke that social and political response, as well as the immediate response that we're providing populations in crisis. The last thing I want to do is thank you very much to all of our staff, past and present, who've been working tirelessly in Bangladesh. That's not just MSF staff, that's the Bangladeshi Ministry of Health, and that's also all other organizations that are working together for this, for the Rohingya population in crisis. So, final thanks to Mitch, to Kate and Melissa for their presentations, and thank you to you for a good discussion. Thank you.